It's my pleasure to introduce our first keynote lecturer, Dr. Doug Koch from the Baylor College of Medicine, the Culinary Institute, a distinguished professor, who in our mind has really made one of the most significant contributions in refractive surgery. We all know lens is also refractive surgery in terms of posterior corneal astigmatism, and just bringing this to the forefront of our understanding about achieving emmetropia in our surgical patients. He's going to be lecturing to us this morning on IOL calculations and challenging us to do better. So it's my distinct pleasure and honor to introduce Dr. Doug Koch.
Thank you, Mark Horney and George. What a pleasure to be here and what an honor to give this keynote lecture. My pertinent disclosure. Okay, well, I think if you don't mind craning your necks, well, I think to keep the meeting going, I will go ahead and talk from that one screen. So I mentioned Svirka Norby wrote a classic paper in 2008, and he reported that the sources of error are ELP, axial length, and refraction. And in terms of what prevents us from getting accurate IOL calculations. But what are the sources of error today? Well, it's still ELP, but now cornea plays a major role. Both the anterior and posterior surfaces, and refraction still enters into the sources of error. Why is axial length off the list? Well, of course, we have these wonderful optical biometers that are so much more accurate than ultrasound. Well, how do we calculate IOL power? Traditionally, we've used classic formulas that are variants of the vergence formula, where you enter the postoperative target of refraction, the corneal power, the axial length. You use a formula internally to calculate the effective lens position, and then you then get the predicted IOL power that you're going to implant. And we wrote an editorial that said it's time to really stop using the concept of generations and talking about formulas, and we should classify formulas by how they work, how they actually calculate IOL power. And we felt were four categories, those that are based on geometric optics that in turn differ by the number of variables they use to calculate the effective lens position. Whether it's 2, 5, as in the Barrett, or the Holiday 2, 7 variables. Ray tracing formulas, artificial intelligence formulas, the Hill RBF being the most notable, they're the more notable of those, and then the combination formulas. But the common goal of all these formulas, one way or the other, is to really basically to compensate or to calculate the effective lens position. Ideally, ray tracing, you would think, would be the best because it incorporates all the aberrations, either of the cornea or of the implanted IOL. We think that one element of this is to look at the axial length in a segmented way, because each region of the eye has a unique index of refraction. And we've been looking at that and have a paper being published in ophthalmology where looking at the concept of customizing axial length based on the refractive index of each portion of the eye. And we reported that for both long eyes and short eyes, the blue is the Barrett formula and the orange is the Barrett with segmented axial lengths. You can see at least at the extremes we could get a little bit better accuracy. But the major limitation of ray tracing is it doesn't provide a unique solution to the ELP quandary. It does no better for us than that. And so the outcomes with ray tracing formulas to date really are not any better than our other formulas. Well, can we improve the prediction of ELP? And there's been progress in understanding ELP and predicting it using OCT preoperatively and intraoperatively. But no studies have shown actually more accurate intraocular lens calculations in doing this. And the ELP shifts unpredictably. A great paper by Nino Hernschall, Oliver Findle and their group showed that 17.6% of eyes had an anterior chamber depth shift of over 1 millimeter or more from 1 hour to 2 months. So we may nail it on the operating room table, and it may change as the patient heals, as we've all seen, I'm sure. Short eyes are more challenging. The data we reported we had an accuracy within a half diopter. This is 22 millimeters or less of 63 to 78%. The Holiday 2 doing best, although there wasn't really any significant difference among them. The reason for the poor outcome is the ELP quandary again, because you have a high-powered IOL in a small, tight anterior chamber with variable lens thickness and pre-op anterior chamber depth, and a small shift gives you a lot of refractive change. We're doing better with long eyes. With our modification, the Barrett Universal 2 has been continued to be upgraded to improve for long eyes, and the Hill RBF as well. So those are good formulas. We looked at data from Dr. Hill using our axial length modification of 1,600 plus eyes with an axial length of over 25 millimeters, 2 IOLs, Holiday 1 formula, comparing the original axial length and the modified axial length, using the U-loop constants for the SN60WF and the manufacturer's lens constant for the MA60 series. And what we saw is that the refractive prediction error was reduced from 0.23 to minus 0.8. The percent of hyperopes was reduced from 60 to 37%. The mean absolute error was reduced. And the percentage of eyes within a half diopter increased from 77% to 92%. And all of these were statistically significant. So I think these and the Barrett and the Hill are really advances for us. And why are we doing better with long eyes? It's in part because the power of the IOL is low, and it really kind of takes the ELP out of the picture in terms of having a major impact on the outcome. Well, what about the post-LASIK eye? We reported in 2015 that the most accurate formula that we saw in eyes with no prior refractive data was the OCT formula, 68% within a half diopter. The Barrett True K now with the IOL Master 700 total keratometry Graham recently reported this at ESCRS, and he got 70% within a half diopter. So we're still bumping our heads against this ceiling of accuracy. I think these measurements of posterior cornea, whether with this device and others, are in the early phases of being incorporated, but we clearly need progress in these eyes. What about keratoconus? Well, that's a bigger challenge, as I think we all probably experience in our practices. And these are data that are compiled by my colleague Smitra Kandawal, data from our group, Darcy Woolsey and Bob Sione, and from Rudy Knight's group in the Netherlands. And we find that the steeper the cornea, the greater the hyperopic error. What you have on this is the corneal astigmatism, and this is the refractive prediction area. This is hyperopia. And what's interesting is that if you look at the relative R-squareds, with pretty good R-squared for this regression line in the lower powers, but once you get to the higher powers, there's a huge amount of scatter and the accuracy really falls apart. So this remains a challenge. Which brings us back to the cornea. This patient came to see me on a pre-op day. These are the measurements I got, 43, 2 diopters, kind of getting geared up to think about toric IOL for this patient. But the IOL master didn't give me any K readings, and you can see there's a missing data point, a missing LED reflection down here. So I looked back at my data. I'd seen this patient 3 months previously, and the Galilei had a SIM-K of 44.6, whereas compared to the 43.34 that I had obtained on the day of the pre-op visit, the astigmatism from the Galilei was 0.1 compared to the 2 diopters that I got with the LensStar on the day of the pre-op visit. And you look at the Myers from the LensStar, and you can see also missing data points and irregularity in the same region that I showed you for the IOL Master 700. So we treated this patient. We got great readings a week later, treated his dry eye, and put an EDOF, and he did well. And the lessons are, gets us back to the cornea. It's a huge source of error. It's the one thing we can do the most about in our practices is to optimize the cornea. We do need more than one measurement in order to, and we need to really verify the quality of our data and of our raw data before we use it for our calculations. If at first you don't succeed, I think that precise postoperative adjustment will become mainstream over time, whether it involves some technology that does a curvature change, such as RxSight, or localized refractive index shaping, such as Perfect Lens and Clario are engaged in. So these are exciting technologies to improve our outcomes. Best practices now: use accurate devices, optical or swept source biometry, Multi-zone LEDs for K readings, I think, is optimal. Use the best formulas, verify the quality of your data, and educate your patients about the fallibility of our calculations. Thanks again for the privilege of giving this talk.